Okay, guys. So the whole idea, as I understood, guys, you want to do some practice for the oral exam, correct?
Yes.
Right. And I'll give you some tips and tricks first, before we start doing some practicing. First one, in the exam, guys, try to relax, okay? It's not information really needed in the exam. It's different from the written exam. Written exam, you have to memorize a lot of information. In the oral, no. It's just we want you to know, because we already examine you on the information. We know what's your information. We're not going to test you with the information. We want you to be sure that information you gain it, you can put it in practice and to be on the safe surgery. So most will be a practical. So imagine like you are in the clinic and patient walk to the clinic with this scenario, and just remember what you're going to do. This is the first thing. Just like imagine you're in the clinic, patient walk in with a story, what I'm going to do next, The second thing, don't try to give the answer which you think that the examiner he wants you to answer, Just give the answer what you're going to do, Because if you give an answer, even if it's against or different from what the examiner has, as far you can defense it, then it's correct. So you don't have to answer the way I want you to answer, but if you give me any answer, I want you to know why is that. If it makes sense, it makes sense, Patient came with aortic occlusion, critical limb ischemia. I'm expected to tell me I'm going to do aortobiFEM. But you tell me I'll do axillobiFEM. Okay, it's not what I'm doing, but tell me why. If you tell me so and so and so, because patients are old, he has multiple surgery, he has hostile abdomen, I say, okay, you're right, So this is the most important part, The third part, don't get yourself to trouble. Answer only the questions. Don't try to volunteer any more information, because more information can get you to trouble, I give you a carotid stenosis. What the most common? You tell me like Takayasu, okay? I say, okay, now let's talk about Takayasu. Then you got yourself to trouble, See, so don't volunteer, don't say about something rare. Just talk about things most common, what you see and how you deal with that. And again, information, ask question, just answer the question. Don't give more information, because the more information may get you to trouble. So just answer the question. And the second thing is that you have a time limit. So if we didn't finish the scenario within time limit, even if you answer the rest correct, they will not count for you. I know why they do that, but that's what they did last time, And maybe the reason why some people failed, because even they finished answering all the questions correct, but already passed the time. So what happened? They calculate the time where they finished, and then after that they didn't count anything. So, and this is not your mistake, must be examiner mistake, because you have to look at the time and be sure you are within the time. What else? I think this is the main things. The second things, if things you never saw it, don't do it. Like I give you a patient with a large thoracic aortic aneurysm, and I tell you what I'm going to do with this one. You told me I'll do an open repair. I say, okay, tell me how you do an open repair. Then you got yourself to trouble because you never did the open repair. And I can tell with a couple of things that you never did it. So this scenario, if you never did the surgery, tell him I never did it. I refer to the, to the specialized center to do it. But I read about it. I tell you how can be done. You see, so it's different, So you can tell him, okay, I didn't do it. I refer to specialized center, but I know the step. If you want, I can tell you what the step 1, 2, 3, 4. But I will not do it because I never did it. Okay. So this is very important. But of course, this is for rare surgery. I don't expect from you to ask you about carotid surgery. You tell me, I don't know, or refer to center. No, this is a common surgery. I'm talking about a rare surgery. Again, like maybe thoracic outlet syndrome. You don't do guys many. Maybe for thoracoabdominal. And the most important, we have to feel you are safe. And you can stop anytime and get referral to second opinion. Okay? Any question before we start? All right. The problem is that, guys, you only have 2 weeks to go. I mean, I just noticed that we have a very short time. We have a lot of subject. So we may have to do 2 or 3 review per week because only this week and next week. So we have to do more often review to start practicing, okay? We're going to start today with the carotid stenosis. This was the request. So I'll give you a scenario. One of you guys, you go through scenario, I'll give you a question, and we go through the question. We have very quick. We have like, as you are 4, I have like 8 scenario. So everyone will get 2 scenario, and hopefully good practice. Okay.
Okay.
All right. Let's go and start. Muhammad, you want to start?
Okay, Dr. Samer.
See my screen, right? You see my screen.
I can see it. Yeah.
Do you see my laptop or just a screen?
I see the PowerPoint program and yeah,
Okay.
and the slide on the side and yeah, and the cases zone. So Bismillah, 72 years old man with distant history of smoking being followed up for carotid stenosis. He denies any history of stroke or TIA. He's on aspirin and high dose of statin. Carotid double artery duplexed is more than 70% stenosis of the left internal carotid with peak systolic velocity 350 centimeter per second and end diastolic velocity is 145 centimeter per second. He's able to walk a mile without a shortness of breath, and he has no cardiac history. He had no previous surgeries or radiation to his neck.
Okay. So this was here will be given in the exam. You give you this written on the paper. So you read this one. Okay.
Mm-hmm.
Okay. The first. Why? Sorry. I have to give one by one. So I got this one. So the first questions,
Mm-hmm.
I'll try to get it. What's your next step? What you do next?
Okay, I'll take more history.
Okay.
History of stroke, TIA, lateralization symptoms, history of eye symptoms, which hand is dominant, and how functional is the patient, type of work. Then I will go through the all risk factor, including diabetes, hypertension, dyslipidemia, smoking, and how much this patient is controlled. Then I will go to the other disease that it's look like coronary artery disease, carotid artery disease, including history of coronary artery disease or history of peripheral artery disease. Then I will check how's the patient fit for or no for surgery,
Okay.
any neck problem, any neck radiation, and yeah, I think this is most of it.
Okay, but why talk about surgery? I said, as
Yeah.
I said, it's okay.
This is for history. I mean, like full history.
Right, but Muhammad, this is too
Yeah.
much information. What
Yeah.
you do
Okay.
next? I do a physical exam, complete physical exam. I
Mhm.
look at his motor function, proximity, any sign of aphasia. I do complete neurological exam. Okay,
Okay.
that is what you
Yeah.
want to, because we didn't decide about surgery. Why are you doing all these things? Because I'm saying,
Yeah.
imagine in the clinic, what are you going to do?
Yeah,
Again,
history and physical exam mainly.
yeah,
Yes.
you're in the clinic, patient came, is going to examine him, see if he has any neurological symptoms, does he have any weakness, no symptom, any slurred speech, right? We're not going to check
Yes.
his heart or everything.
No,
Again,
no.
try to be practical, you see? So
Okay.
you're in the clinic, this is what we're going to do next step. I'll do a physical exam, I check his motor neurological exam, okay? Then you stop, okay? So your physical exam is negative for any abnormality, okay? So what your next step? So you did exam, he's normal. So what next step? So he has high velocity, more than 70%, So
Yeah.
are you in the clinic?
So he's asymptomatic carotid stenosis now with more than 70%. I need to make sure that he's medically optimized in this medical therapy. I'll start him in first. Start him for first line as best medical therapy, which is statin and aspirin now.
Okay. So this is 70% stenosis, correct? And he's
Yes.
asymptomatic, correct?
Yes.
What the guidelines tell us about asymptomatic 70%?
That there is a risk reduction per year for the stroke.
There is indication for surgery or
Yes,
no?
there is indication for surgery. If this patient can live for at least 5 years, there is
Okay.
significant reduction in stroke rate in this patient compared to best medical therapy.
Okay. You see, so your answer will not be what your answer is correct, but again, it's not the way. What your exam is negative for abnormality. What your next step, as you said, this patient is fit the criteria for surgery versus medical treatment. So now I have to think, is it good for surgery or medical treatment? Then I have to look to do a surgery for asymptomatic. He has to live more than 5 years, and my stroke rate should be less than 3% stroke and mortality, So this way, and now I start evaluate the patient to see, should I take him to surgery or continue conservative management? So then I talk about his fitness. I ask about, how's he walking? Does he have any major medical problems,
Okay.
But you see the thought process, you have to tell me that now I am between two options, either medical treatment or surgery. I'll decide surgery if he's fit and if this or more than 5 years and he's medically fit, or
And
if
my
he has a
stroke rate
criteria
is less
on,
than.
or if he has a criteria on ultrasound or CAT scan. This is one options. Or I can go with medical treatment because this is a gray area. You can go both way, So at this time, I start thinking, because from the beginning, before you go to the sign on the CT scan or ultrasound, first see if he's fit. If it doesn't fit, then that's it. We're done. Our medical treatment. If he's fit, then I have to go with further testing to see, like does he have a high risk, factor for for stroke, like the plaque characteristic and other things, So next step I will do, you tell me like, we can go on this patient, we can go both way. It depends how he feel, how he's physically fit. Is he physically fit, then I'm re-evaluating for surgery. If it's medically not fit, I think with this one, it's asymptomatic, we can go with the medical treatment only, with his aspirin, Plavix, and modify his risk factors, okay?
Great.
Right. Okay. You said that. So now patient asks you why you want to do a surgery. How is different? What the data tell us about stroke rate reduction 1 year with up to medical treatment versus CA?
So for the asymptomatic carotid stenosis, we have a cast. It showed that the best medical therapy for 1 year is decreased to 1% compared to 2% in best medical therapy. Yes. So over 5 years, they have a chance that he will have 5% reduction compared to the best medical therapy, and it showed that it can reach up to 20% in if he's more than 10 years.
Okay. You see, it's also a good answer, Muhammad, but again, the long answers,
Okay.
much time. What could put the patient risk stroke reduction 1 year without the medical treatment? You told me his medical treatment is 2%, with the surgery 1%, we have 50% reduction. That's it. Stop.
Okay.
Information 10 years on ACAS or ACAS, about ACAS. Is I'm telling you, don't get yourself in trouble.
Okay.
That's the question. Go directly to the question, to the answers. This is a question. Start is optimal. How much? I get 0.5% reduction from 2% to 1% per year if you do a surgery. Okay.
Okay.
All right. Next question. Patient status that his father had a stroke and he has seen how devastating that can be. He would like to proceed with surgery. Is there any testing you would perform prior to surgery? So you decide to take him to surgery.
Yes.
You going to go with this one, going to do another test.
Yes, I would like to get CT scan.
Why?
If I'm planning to surgery. Now the surgery planning, it requires CT scan to check the neck and the level of the bifurcation and the magnitude of the is it focal or a very long segment? To check the carotid stenosis itself.
Okay.
Mm.
Yes and not, because other people, they do it on the ultrasound, you know.
Okay.
So yes, you do a CT angiogram, but not for that, not for bifurcation. Bifurcation can do an ultrasound, you see.
Okay.
I do a CAT scan to confirm the degree of stenosis, because you
Uh,
tell me ultrasound is a dependent on the, you know, it's radiology dependence, you know. So I
Okay.
need to confirm it before, you know, before I
Mm.
proceed with the surgery, period, you know. So I'll do
Okay.
CT scan before I proceed surgery, so I know where to confirm the stenosis, you know.
Mm-hmm.
Okay. All right. What type of neurological testing you would do? What type of neuro monitoring would you use and why? Sorry.
Yeah. Yeah.
So you're gonna do a
So
surgery,
yeah.
you know. Before surgery, what else you have to do? What else? You said the CT angiogram. What else you need to do? Sorry, before we finish. What else you need to do?
So he needs to be cleared by the anesthesia.
Correct.
He needs to have ECG, chest X-ray, and formal pre-operative assessment. And depending on the anesthesia assessment, he might need an echo. This is
Okay.
the major thing.
Sure, we
Yeah.
had an echo all the time, most of the time, yes. But we
Yeah.
need echo and EKG. I don't think
ECG and
because he's healthy guy, as they mentioned, he's walking fine. So I think EKG, echo, and chest X-ray is enough. You know.
Mhm.
Right. Okay. So now you take him. You're going to do how you monitor his brain during the surgery. It's a very important question.
Yes.
What do you do?
So I'll
Don't tell me,
there is
oh, this or
different.
this or this. You see, in the oral
Yeah.
exam, you can't tell me I can do this one or this one or this one or this one, because I
Yes.
want to do what you do. Like tomorrow, you can take it, because guys, you are consultant now. You can take patient surgery tomorrow. So I want you to know what you're going to do. And any answers could be correct as far as you tell me why. You may tell me I'm not going to do anything. I'm going to do like a weight. Okay, it's okay. You may tell me I want to do it, but whatever you want to do, tell me why you want to do this one. So for real, if tomorrow they call you for carotid, what are you going to do? How are you going to monitor your brain?
Yeah. I'll use the same way I was trained of. I will I'll put him in neuro monitoring and will check the oxygen saturation with the pads, and I'll take this one as my wave monitoring.
Okay. Is there any other way, or is this the only way? Now
Yes.
I can ask you. Wait.
Yeah. So there is an awake assessment with local anesthesia and serial neurological examination during the procedure.
Okay.
There is testing the backflow stump, which is mainly checking with the
How much the pressure be acceptable for you?
uh, anything more than 25, it's great. A 40 to 50 is the optimum.
Yeah, no,
Uh,
50, 40 to
yeah,
50, 20, 25
yes,
should be
yeah,
50. And above,
okay.
okay, so
Mm.
lower than 50 is better. Okay,
Better pay
let's say,
position. Okay.
so you don't have a TCO2. What do you need to do? You can hospital, went there and they ask you, sorry, we don't have it in the hospital. So
Yeah.
what going to
So
do?
if I don't have any, I will try to find out what else they have. If
They
they
don't have
don't
that.
have no neuro monitoring available in the hospital,
Hmm?
I will reschedule the case till I have it in the hospital,
Yeah, but this is
because
maintenance.
it's occurred. Yeah, and I can shunt all my patients during this time. If it's yeah,
Yeah, this is a question. Then you can
yes,
answer. Then you do it awake, while patient
or
awake,
yes,
or I can do it. Is the answer. So if you don't have
yeah,
them, I do it in awake, or I can do it
or
with a shot.
all shunt. Yeah,
Yeah, and I just had
yeah.
a case like last week. They told me one of the lead of the TCO2 is not working. And the moment I knew they have a problem, I said, forget about it. I'm shunting at that, you know.
Okay.
So always is a, but don't wait for us to get you something. Always is an adjustment.
But even For asymptomatic case, I know for symptomatic is different, but for asymptomatic, like this patient, and if they told me in real life, if they told me they will get it to me, but not now, should I wait or should I just do it with a shunt?
I mean, you know that there's none of them is accurate. There's a reason
Yes,
why
all
I
of
don't
them. Yeah.
only one of them, you know? Like you
Mhm.
see TCO2, I don't depend on TCO2, I depend on TCO2 and the pressures or the retrograde flow, you know?
Yeah.
Because all of them, they have a false negative, false positive, you know? So always it's
Mhm.
better either to do two methods or to do
Mhm.
underlateral or do a shunt to be on the safe side. And asymptomatic is more important because your stroke rate should be less than, with a mortality less than 3%. So because if your mortality, if stroke rate is more than that, you lost the benefit of asymptomatics, you know, so it's very important in the asymptomatic to monitor the brain, be sure patient doesn't get a stroke because you're doing a
Okay.
prophylactic surgery, you know, so it's very important.
Mhm.
All right.
Okay.
Um, So, okay, so now take me through the surgery. We're going to do surgery. So, patient now, surgeon in the OR, tell me from placement, because this was the oral exam. It's mainly
Yeah.
technical, okay? We want you to know, you know how to do it, okay? This is how the exam, all right?
Okay.
I'm not to ask you about velocity and mortality and morbidity and complication. I'm asking you now. So tell me how you take patient to surgery. So patient in the OR, tell me how you're going to prepare the
Between the
patient.
war, I'll start with a briefing and making sure the position I want the patient is head and head position is elevated with neck extension and rotation to the contralateral side of the surgery. I will ask the anesthesia to put the tube in the the other side of the surgery, and make sure I have batch and shunt available in the room. Start with surgery, prepping and draping and longitudinal incision along the course
You
of
forgot. What
anterior.
did you forget? You forget
Hmm?
something. You forgot something. What do you forgot? Before you start, because you're going too quick. So now we did
Yes.
anesthesia, position him, you're going to start cutting, right? Before that, what did you forget? Shoulder
Before
roll.
I,
Shoulder, shoulder roll.
shoulder roll. Yes, I have to put shoulder roll for the neck extension and
Yes.
yes.
So because you see, I want to know what your step you're doing. You know, I want to be sure that you do that. So you put a
Yeah.
shoulder roll, you extend the neck to the other side, you prep, and now you insert incision. Okay, how's your incision now?
As my incision is longitudinal incision along the course of the sternocleidomastoid with
Okay.
just anterior to the sternocleidomastoid through the skin, subcutaneous tissue, platysma, avoiding or ligating of the external jugular vein if I can, grow just anterior to the sternocleidomastoid, start dissection downward and anterior to the internal jugular nerve vein and vagus nerve. I should see the common carotid artery. I dissect around it. I got the with the right angle and lower, I get the vessel loop around the common carotid artery, and they start to dissect upward to the external and internal. I try to visualize the external by locating the superior thyroid artery and
Muhammad,
getting the
stop.
facial vein. Yeah.
Okay, you're doing correct. But when I ask about the steps, I need the general steps. You know, one, two,
Uh,
three. We don't have much time. You know,
uh-huh. Okay.
this
So
is
yeah,
diagnose
yeah,
muscle, muscle,
yeah.
identify
So
the jugular vein. Okay,
yes,
you push it medial or laterally?
I
Lateral,
I push it laterally.
laterally, correct. Then
Yes,
you
and
take the common internal external. What nerve you
yeah,
looking for? Two nerves.
hypoglossal, glossopharyngeal. Uh,
Glossopharyngeal.
so answer cervicalis, hypoglossal, glossopharyngeal, vagus nerve. This is
Vagus.
the common nerve. Yeah, this is the common nerves
Okay,
in this
so you did
area.
that. You expose everything. Next, what you do? Next.
Next, before I prepare my clamp, I make sure that the shunt is fully irrigated. I have the batch on the table opened and ready. I ask the anesthesia to give patient heparin, and I prepare my
How much
clamps.
heparin? How much you give heparin?
It's around 1,000. Sorry, 100 100 units per kg. So
Correct.
usually, if it's 70, he will take 7,000.
Okay, so 80 to 100 unit per kilogram. And
Yes.
ACT should be more than what? ACT,
250.
more than 250. Okay, this is correct. So
Yeah.
you did that, you ate 5. Before you do that, two things you missed. First, when you dissect at the carotid body around it, always
Yeah.
you have to tell the anesthesia, they may go to bradycardia. So you have to be careful with that.
To
Some people
prepare
even have
atropine.
yes, some people even have lidocaine on the table just in case if you have any significant bradycardia, you can infiltrate the carotid body and to stop the bradycardia. So I have to tell them. So every time I dissect in this area, I tell the anesthesia, let me know. Because anesthesia doesn't know. You see bradycardia start giving atropine. He doesn't know what's going on. But if you tell him, because it's easier to treat from your side. If you had the bradycardia, just get some lidocaine 1% injected between in the carotid body and then will resolve, quickly.
Yes.
Always tell the anesthesia. Then you did everything's correct. You dissect, you give heparin, okay? And then you wait a couple of minutes, and then how you clamp now. Next, what you do? Show me how the clamping procedure.
Yeah. So I'll start clamping the internal, then common carotid, then external.
Correct.
Yeah.
And then you do
And
what you
then
do.
I'll start. I'll ask for 11 blade. I'll start my arteriotomy, starting from the common carotid, pointing toward the internal carotid with
Okay.
a butt scissor. And as long segment I want to, I have to have a good control distal to that.
Okay.
After that, ask for black elevator and start to get the black out,
Okay.
and making sure that distally I had a good ending point, and if I need tacking suture, I tack it there.
Okay.
Flush the carotid, and I start my batch repair.
Okay. You finished.
Different
That.
different technique in batch repair. I'll choose the which is easiest to me, which is I use
Okay.
stitch in the beginning, and I just run it as with 6O Prolene running suture.
Okay. That's enough. That's enough.
Yeah.
You don't have much time in the exam. So you just do
Yeah.
your patch and that's it. You patch and everything is fine. I don't have to
Yeah.
know details. I know how you sutures.
Yeah. Okay.
But you patch it, okay? And then after
Okay.
you finish, do you do
Uh,
any study to confirm your study, your
I will make sure that I have a Doppler in
okay,
the room, and after declamping, I'll declamp first to the internal carotid, then reclamp it again, then opening the external and opening the common carotid to the external. I'll check with the Doppler signal, distal and mid to the batch repair for the signal.
so you unclamp first the external.
Yeah. First I declamp the internal, then I reclamp it,
Yeah,
then
but
I
see,
open the external.
Ahmed, this is what
Yeah.
I do, but people they may not understand that. They may get confused. I will not do
Okay.
that, you see, because if you tell them that, they don't
Okay.
understand why you unclamp the internal, they don't understand this concept,
Yeah. Okay.
This is what I do.
Okay.
So no, you
Mhm.
said
Okay.
the external, the common,
Uh,
and then last thing I
yes,
open
and I
it
flush
quickly.
this.
Okay, so that's what I do.
Yeah.
External, internal, common, and then internal. The opposite, you do it.
Okay.
All right, so
Okay.
you do that, and then I want to confirm that you study Dabra. Dabra is good, but Dabra doesn't give you really much because you can put your hand feel a pulse. So
Mm-hmm.
usually I don't do, you know,
Mm-hmm.
usually it is enough for me. But some
Mm-hmm.
people they do a duplex ultrasound. A duplex ultrasound for two things. First, to look for if any flap, because you can't catch it with a Doppler if you have any flapping inside, or if you have an obstructive, waveforms. Like if you have a distal occlusions, you cannot tell unless you see an obstructive waveforms.
Yes.
Um, so some people do that. Again,
Yeah.
I don't do it but you can tell him I don't do it, but some people do that. Or you can just
Yeah.
say I'm done with that. If he asks you, do you want anything else? I say yes. I read that some people do a duplex ultrasound, to check for flapping or for obstructive or high resistant waveform, which is mean that something wrong.
Yeah, but it's the voice is very obvious even in the Doppler, doctor. Like the obstructive waveform, it's
That's correct. This is
very
correct.
yeah,
But you cannot see if any flap there. Correct.
yeah,
That's
yeah.
a problem.
Okay,
So this is
yeah,
not enough.
okay.
Either you want to do something really important or don't do it.
Oh, yeah, sure.
If you want just about, yeah, but anyway, I mean, this one
Uh,
you can argue about it,
yeah,
but I can stop here. All
okay.
right. So, what finding on the completion? You see all the question, right, guys, or
Yeah,
no? You
yeah,
see
we
them.
can see it. Yeah,
It's supposed to go one by one, but it's okay. I don't know. Sometimes my
okay.
computer. What finding on the completion typical ultrasound warranty for the investigations? Okay. So what do you think in what we just said? We said what
Yeah,
finding I can tell you if you have any
flow
flap.
limiting dissecting flap,
Okay.
thrombus at the distal anastomosis, a clamp injury maybe. So yeah, this kind of things.
I don't know what you mean by flow. You see, now you got to double. If you told me
Okay.
just flap, I will stop. It's okay. But now you told me flow limiting, flap. I'm going to ask you, what is flap limiting flap?
That there is a significant change in the velocity between proximal and distal to this area.
All right. So if you
Yeah.
see a flap going and velocity is not increasing, you're happy with that?
Yes, that
No,
means it's not loaded. Oh, okay.
no. Usually the flap
Mm.
is more than 2 millimeters. It's what I'm saying. You get yourself to
Yeah,
trouble. Tell me, you just say a
yeah.
flap,
Okay,
high velocity is okay. But now because you told me criteria, they tell you what criteria you're looking for. The criteria you're looking for, if it's more than 2 millimeter flap, this is considered significant. It's nothing to do with the velocity. It's how much
okay,
the flap going up. So if it's going more than 2 millimeters, they consider a significant flap, then you have to tag it, okay?
okay,
All right. Because the flap could be in the common carotid and, like at the origin of the internal carotid artery, which is very wide because just put a patch will not cause for you. Because the flap is not, you're not worried about thrombosis to be like a flow limiting, like lower extremity. You worry
Mm,
about flap can cause TIA because keep moving and cause emboli, That's
yeah.
why I worry about the flap mainly, All right. So let's go to next number 8, 9.
Mm,
Wake up and has a normal neuro exam in the OR. But after an hour in the PACU, he developed a dense right hemiplegia and slurred of the speech. I'm telling you, you're going to get this question. I mean, they love these questions,
okay.
So what are we going to do?
So I'll do bedside ultrasound duplex at the recovery, and to check the carotid itself if it's thrombosed or not.
Um,
So there is two ways, doctor. This is even written in the book that I can send him to
I
CT
don't care
scan
about
urgent.
don't tell me
Yeah.
about the. You see, this is wrong answer.
Mm,
Don't tell me about
mm,
is an exam. What you want
mhm.
to do? I don't care what Schwartz going to do or Rutherford going to do. I want you what you do.
Yeah, I will do
Wait out
bedside
the
ultrasound.
exams.
He's still in Baku, so I'll
He's
do
back.
bedside ultrasound. Yes,
So you can to time get an ultrasound.
yes.
Okay. What else you want to do?
I can send him for CT scan too.
Same for
CT
CT.
angio.
Okay. No, I think no. This is wrong.
Okay.
It's very important because you are in the recovery, and they
Mm-hmm.
call me saying patient has stroke. He was fine and has a stroke. Correct?
Yeah, I return him to OR and they do duplex ultrasound in the OR.
Let's see what happened. For let's understand
Okay.
what do you think is
Okay.
happening? Do you think it's an emboli or thrombosis of the surgery side?
I think the thrombosis at the batch area.
Yeah, because if it's an
Yeah.
emboli, he should see it right
Yeah.
away. Patient should wake
Yes.
up with a stroke, correct?
Yes. Yes.
Because if it's an emboli during surgery, he should not wake up. He should wake up with deficit. But he wake up fine, and then suddenly he got a stroke. So that means most of your bifurcation thrombosed, you know. So first thing you call the OR, because OR, this is time, time, brain is time. It's well known, First thing, tell the OR, tell him I have an emergency, I'm planning to take him back. Okay. And then I call for the duplex scan. Don't get stat duplex scan and then call the OR because it's wasting of time. Okay. So the first thing said, you call the OR, say I'm taking patient back. And by the time they get the room ready, everything, I get, okay, give me stat duplex ultrasound to look what's going on. The third thing you do, you increase blood pressure because the brain depends on the systolic blood pressure, So you want to increase blood pressure to around 160. Like I say, when we clamp, So you tell him increase blood pressure, call the OR, and get stat duplex ultrasound. Okay. So you get a duplex ultrasound, and it found that the card bifurcation is thrombosed. What do you do?
So
Taking the OR, right? We just
yeah,
said
I'll open. I will resect it.
still open. So you take the
yeah.
OR,
Yes.
right?
Yes.
Okay.
Oh, yeah.
What else you do? You see, I want to know step by step. What are you doing? Like you're in the recovery. Okay, they call you, call the OR.
We started increasing his blood pressure. We'll take him for OR for thrombectomy and check
the
the.
OR. What do you do?
Before I take him to the OR, I start him in heparin.
Yeah, right away. You see, you have to tell me these things,
Yes.
Because the intern there doesn't know. So you call me. I said, Dr. Koussayer, I have patient has this way. I say, okay, call the OR, get stat duplex ultrasound. Okay, get ready, increase blood pressure. Okay, duplex ultrasound, show me his occlusion. Then okay, start him on heparin. Let's go to the OR. But start heparin right away. Give him full dose of heparin. Okay.
Yes.
So we give him heparin, take him to the OR. Okay. So what do you do in the OR now? What you do?
I'll open the same incision. I'll go same steps, and I will clamp, and I will open the patch again.
Correct.
And do thrombectomy and check distal and proximal, and
okay, how do you thrombectomy? Just a second, stop here. How do you
localized thrombectomy? So I have it. It's in the batch.
You don't get Fogarty?
No, bro. No, distal. No, I'm not do Fogarty. Blind Fogarty.
Okay. Usually we do, but a short one, like get 2 millimeters, and you don't advance it more than like 3-4 centimeters, like around the area of the ear, just to be sure not distal. Because if you do local, could be something a bit more distal. Of course, not going to go all the way to the brain.
Next thrombectomy.
Centimeter and pull. Just be sure I pull everything and good back bleeding.
Okay.
And then I took the clot, and then what after you do that? After you took the clot, you do thrombectomy, good back in inflow, outflow. What do you do now?
I'll need reconstruction. I will check the artery itself. If I can batch again, or I'll bring interposition graft, either Dacron or vein.
Okay, this is wrong. Why you need to do that? Why you need to do interposition graft?
If there is severe dissection, I cannot solve by batch again, and that's why he thrombosed in the first time. I need to do interposition graft. If it's rebatch, if I can't put the batch safely again, I will just do the same thing with batch.
Okay, well, let's go back to my dad. I misunderstood you. How did you open him? You take the patch out?
I'll cut through the batch.
Okay, so the batch still there.
Yes.
So we just cut through the patch. We open the patch, we see the clot, we do thrombectomy, we pull the Fogarty, we get good back bleeding. Then you have to look, say, why this happened to me? Then you have to look inside. Most of you get to find something, either a flap or most of you can find a flap. A big black, you forgot to take it or something like that. You just clean it up, you fix it, and that's it. Then you close your patch, and So this is the best way to do it. So you just try to figure out, but don't jump to interposition. I don't think you need to interposition because most of it will be just flap or small, I think, flap. That's all what calls that. Unless if you have something distal dissection, it's different story. Then you have to stand all the things. Okay.
Okay.
Okay. So let's say, I mean, you get back bleeding, but there's flap at the distal end point. Nicely, there's a flap at distal point. How would you address that? Is an 8 flap at the distal point?
At distal point, if it's beyond the surgical area, I can stent it, and I will try to stent it. Yeah, for stenting.
You see, you didn't understand the question, maybe correct. What he means that you open and you found that the end of your patch, there's a flap there, you know? So what going you go do a stenting there? Why, you're already there, you're doing surgery, you're already open. Just open, extend up, fix it, and extend your patch up. You see my point? Like when you see, unless if it's too high, you cannot see, it's different. Yes, then I agree on stenting, you know, but as you are open, and you see the flap at the end of your, you know, this is what usually happens at the end of your patch. Then I get my mitts, I open the internal more, about 1 centimeter, so I can see the flap very well. I fix it, and I put a small patch in this area, which I opened. Okay. If it's too high, you cannot go higher, you're already very high, then yes, I'm gonna go through stenting. And how do you put stent? You still there, Hamad? Hello?
Hi, doctor. Yes, for the stenting, I have to. Now the artery is open, so I need just to just to stent it. But I want to know in this situation, I can put sorry, what is it? The filter or no?
Filter or no? No, you don't need a filter in these situations.
Okay.
Because there's no plaque. You know, you already took some
Okay.
plaque, you already just have flap, you need to fix it. So I don't, you know, but which the approach you're going to go? Where are you going to go from?
The same. The batch is open, so I'll just do it from the
Patch.
yeah.
I
But
don't
there is no space. I don't think there is a space. Yeah.
know.
Oh.
So you go from the common carotid. It's
Common,
easy.
common carotid back. Yeah. So T-car. Yeah.
Yeah, the T car, but you go from the common carotid.
Yeah.
Because
Yeah. Okay.
you just go from the
Okay.
common carotid, and you just put the air wire, put your sheet, the angiogram, put a stent, and get out of it. You know, I'm done. If you think it's too high, I prefer to do surgically, but if it's too
Okay.
high, flat, then I will do that. Don't go from the femoral, and because your table is not angio table, you see, everything is practical. You see, everything is practical in the OR. You see, if you're going to go from the femoral, if you tell me go for the femoral, I'm going to go through the femoral. The table is not fluorescent. You know, this is a regular table. Then you're stuck. I'm going to go through that, and you know. And then you don't know how is the arch, you may get more trouble, you know, where
Yeah.
you already open, common carotid there, maybe extend your incision a bit down, you get more common carotid, get your needle, get your sheath, do an angiogram, put a stent, get out, and you're done.
Yes.
All right?
Yeah.
All right. So how you like it so far?
Very realistic, Dr. Farid.
Again, this is what your exam read. Exactly what I did now. This is the exam. It will be a bit faster. But again, this is what we want to know. We want you, what you do. You are in the OR, you be a consultant next week. How going to practice? How going to do? What are you going to do yourself? You know, I don't want differential diagnosis. All right, let's get Sam to the second case. Sam, you want to go to the second case?
يلا توكلنا على الله بسم الله. بس مش واضح كله. اوكي. A 75 years old woman who is an active smoker presents to the emergency department with a left facial droop that resolves shortly after arrival. She has no significant past medical history other than a distant MI. Physical exam is unremarkable, other than some mild slurring of her speech. ECG shows she is in sinus rhythm.
Okay.
Okay.
Was TIA, right? Because the
Yes.
result.
Goes with TIA.
No,
Symptomatic.
has only distant MI.
Yeah.
EKG sinus, so don't think about atrial fibrillations.
Yes.
Yeah, some slurred speech of her speech. Okay.
Yeah.
So we'll talk about which carotid, right or left?
Fascia droop to left معناته left carotid.
Right. And the speech also. Also, she's a dominant left, so mostly it's the left side. Okay. So let's go to the question. So what do you do
Okay.
next?
I will do proper history and physical examination.
And it looks she has a facial dropping on the left, and she still has slurred
Yeah.
speech.
Physical examination will concentrate on pulses and neurological deficit.
Correct.
Yes.
What else? What tests in any order? So this is came back. No, I mean the same as you said. You did exam. That's what she has. So what do you do next?
Doppler ultrasound, duplex ultrasound.
Okay, so you did like ultrasound and showed you have 70% stenosis of the right internal carotid artery and 40% of the left. CT head is normal with no finding of acute stroke. Okay.
Okay. Okay. So يعني معنى الكلام إنه he's trying to يعني إنه we'll go for medical treatment because less than 50%, although she's symptomatic, but less than 40% will go for medical treatment. But yeah, let's go through the question. How long would you wait prior to carotid endarterectomy?
You know the question? No. This I ask a question. No. This question I will ask you. It's an example. So let's say, I mean, the 70% on the left side.
Right side.
Let's say on the left.
Okay.
So what do you do?
If the stenosis is in the left, then I will consider it as symptomatic. 70% will she needs intervention. But yeah, so we'll go through the measurements for the fitness to decide which way for intervention, either open, endovascular, or medical treatment.
Before you go to that, what are you going to do? Because you only have a duplex ultrasound. You are in the clinic, okay?
Yeah,
Patient
CT done.
Yeah, let's see.
Yeah, but he said CT. The CT is only head. Okay, so we'll do CT angio to confirm the degree of stenosis.
Okay. So you did a CT angiogram and confirm you have 70% stenosis. Okay.
In the left side.
On the left side. How long
Okay.
would you wait prior to carotid? And is there any test you would order prior to your operation?
الصوت واطي دكتور سامر بس معلش تعيد السؤال.
How long would you wait prior? Number 3. How long would you wait prior to CA?
Yeah.
Are there any tests you would order prior to operation?
Okay. So how long I would wait? I'll wait for 48 hours, not before 48 hours. For يعني 48 hours to 2 weeks. This is the duration for intervention. And what test I have to do? I will do ECG, echo, chest X-ray to assess her fitness for general anesthesia.
Okay.
Or in general.
You do stress test?
She had history of distant MI, so we might need to go for stress test, yes. But echo is not enough.
It depends on what the echo showed, but you may consider it, But yeah, should be an echo.
Yeah.
Echo showed something, but she has distant history of MI. Unless is she diabetic? Let me see. Unless she's diabetic, then it'd be different. Active smoker. No, they didn't mention anything about diabetes. So yes, I mean echo could be enough, but you may leave it to the anesthesia to decide if they need a stress test or not,
Yes.
All right. So the CT showed a focal bifurcation lesion with an intact circle of Willis. Describe your operation. How you do a surgery. Same things. Let's go through a surgery.
Okay.
Just give me a step. Don't go into detail. Just give me a step. Patient, position,
Okay.
incisions.
So yeah, we'll start with general anesthesia. بعدين position of the patient, shoulder roll, extension of the neck 45 degrees, face to the contralateral, then prepping and draping, oblique or longitudinal incision just anterior to the sternocleidomastoid. We open the skin platysma and we identify the internal jugular vein. We push it laterally. Then we identify the common facial vein, ligate, identify the common carotid, external and internal carotid. We identify the nerves, hypoglossal, and try to save it. Hypoglossal and vagus nerve. Then we start with the control. Before control we give therapeutic heparin.
Yeah, let's not go through that. I already through that, so let's not space
Okay.
our three of the steps. Okay. The
Okay.
most important that before you clamp, what you ask the anesthesia to do.
Yeah, we give heparin, therapeutic, full dose, 80 to 100 unit per kg, and to keep the ACT more than 250.
What else?
Monitoring before clamping to make sure that the monitor is equal or
What else?
of the cerebral.
Remember, what when you do surgery, what else? What we tell the anesthesia?
Also during this to keep the blood pressure high.
Yes.
And to monitor if there is any bradycardia to inform us for
The most
infiltration of
important
lidocaine.
blood pressure. You see, I don't clamp until it's become like 140, 150, 160. So
Yeah.
120, 130, I don't know if you remember, I just wait until the
Yes.
pressure is really high and then I clamp. So it's very, very important to get the pressure high before clamping. Even if you use a shunt, whatever you do, you have to have high pressure. Okay.
Okay.
Okay. So are you going to shunt, not shunt? What about your way in neuro monitoring? Do you do neuro monitoring? You do a shunt? So how do you decide what to do? What do you do? If you have a case,
Yeah.
what are you going to do?
Yes. يعني I'm not shunter all the time. I will observe the monitor and the backflow.
Monitor.
Cerebral monitor, the neuro monitor.
You do
If
TCO.
there is, sorry.
Which one? TCO2? You do that?
The pads on the forehead ايش نسميها cerebral monitor.
Yeah, TCO2. Okay, so
TCO.
you do that. And what else you do?
Also, we observe the backflow.
Okay. What the back pressure? We talk about it. How much back pressure will be?
Less than 50.
Less or more?
احنا بنتكلم على الستامب بريشر ولا على الباك فلو because the back flow is يعني relative.
لا بنحكي على back pressure.
على الستامب بريشر.
Pressure.
ستامب بريشر يعني لو if يعني مفروض تكون less than 50 or more than 50.
لا في فرق. شوف
يعني
يا على يا اوضح يعني يعني when are you going to shunt? If it's less than 50 or more than 50 you shunt.
if it is more than 50
then you shunt.
you shunt. صح؟
صح.
يعني انا كنت بدي اسالك والله هالسؤال قبل ما نبدا.
Okay, that's good. No, that's good. It's okay, guys. We have a few exams here. It's not an exam. It's better ask now than the exam. No, that means when you have more than 50, that means you have good collaterals. So you don't need to shunt. You see?
Okay.
High pressure is good. That means you have good collaterals. When the pressure less than 50, that means collateral is very weak. Then you have to shunt. Okay? So if the pressure, stomach pressure more than 50, this is good. You don't need to shunt. But if it's less than 50, then it's better to shunt because that means the collateral is not enough. Or circle of Willis, you know?
Yes.
So,
طبعا احنا we don't do it routinely صح؟ احنا it's not available in our hospital or what?
this is not question. The question, what do you do? Bassam, like if you had a case tomorrow.
Yeah.
What are we going to do? Are you going to do it or not? You can tell me I don't do it, but usually this is if I want to do, if I have any doubt, I measure it. You can measure it. It's not difficult. Yes, we don't do it because I depend on how is the back bleeding, you know. But to be on the safe side is really it's better to do it, you know.
Yes.
So you have to be, as I said, in the exam, it's better to be on the safe side, you know, and
Yeah.
something is easy to do it. Like, don't tell them something is difficult to do it, you know. Don't tell them I'll do an EEG and you don't know, you don't have EEG, you know. But stomach pressure is very easy. You know, tell them if any doubt, I just measure the stomach pressure. Of course, you have to know the criteria, because the worst thing, tell him I do stomach pressure and you don't know the criteria. So it's better than don't tell him about stomach pressure. You see, this is what I said, guys. You sometimes you get yourself to trouble. So if you're not sure about something, don't tell it. But if you know, then you tell it. Okay, I measure stomach pressure. If it's less than 50, I go on shunt. If it's more than 50, I feel comfortable not to shunt. You know. Also, I'll look at the TCO too. You know.
Stomach pressure can
anesthesia. Huh?
stomach pressure we can measure it through the Enhara shunt. Is it possible, or we insert
Just like any pressure, you measure the pressure in the artery.
like a small sheath?
No. It's very simple. Just put a clamp the internal, put small needle, 2120, and put it inside the internal distally, and you get the pressure, stomach pressure.
Yeah, okay.
It has to be clamped so you can see a stomach pressure called
Yeah.
stomach. So you clamp the internal and you put small, you know, like maybe 25 needle distally, and you measure the pressure.
Okay.
We put it in the common carotid or the internal?
The internal, distal to the clamp. The internal carotid, distal to the clamp. Okay. If you don't do it, don't mention it. Okay. If you don't do it, guys, don't get yourself trouble. Okay. I mean, the worst thing that I'll do it awake, or I shunt everyone. You know, if he asks you, what about stomach pressure? How you do it? Then you have to know about it. You see, it's different between what you do and you have to know. So you have to know about the information. But if you want, you can tell him, you know, I don't have a good monitoring in my hospital. I shunt everyone. I just put a shunt. Then I tell you what kind of shunt. Then I'm going to ask about the shunt, because I want you to be sure really you do it. You see, the whole idea from exam to be sure that whatever you do is really you do it. You know, it's not theoretical. So if the shunt, I'm going to tell you what kind of shunt you're going to use. There's a lot of shunt, but which one you use and how to put a shunt. The second question, okay, so you shunt, how you shunt? This is the second question. You see, in the exam, all practical questions, you know, we want to be sure that whatever you're saying is you are doing and really you're doing there, okay?
اللي فيها بالونز هذه اسمها انهارا، والثانية اللي only tubes لها اسم
Argyle. اسمها Argyle.
Argyle, yes.
So again, which one, whatever you want, but you should know how it works, because the worst thing, you become a shunt and you don't know how it works, you know? So then I use the Argyle shunt, you know, just a tube, simple tube. I go from the internal first, I check my back reading, and then put it in the common carotid and leave it there. So this is the one. Other shunt, you have Javet shunt, you have the other one with the balloon. But whatever, you can use a balloon, but you have to tell him how you do it, how you fit the balloon, how much you put inside the balloon. It's very important information, you know. So if you never did it, better not to get to this route, you know. Again, I mean, answer a question as short as possible, directly to the point. Extra information, if they ask you, they need extra information, they will ask you, and then you answer it. Okay? All right, so let's see where we are now. How we determine Wallace, how we determine what shunt pressure? She's neurologically intact in the PACU, but her blood pressure remained very high. How would you like to do what you do? Is any problem if the pressure stay too high?
Yes, we are afraid from hyperperfusion syndrome. Correct. So it's better always to keep the pressure about 20 millimерcury systolic as baseline. Yani if the patient perioperatively was 120, to keep it within 140, not more.
Right.
So we need to minimize the blood pressure.
Okay. You see, this is Bassam is good for oral, for written exam. For oral, I want to practical. Like, and they call you now, you are in the ICU. They call you from recovery room. Okay, you're a consultant. Yes. I have patient pressure is like 160, 180, 190. What shall I do?
Okay, we ask the anesthetist or the PACO to give antihypertensive medication like hydralazine, stat dose, to keep it lower. within 140 to 160 systolic.
Okay. But patient has a chronic hypertension and they give it that and still pressure high. What do you do?
We send him to ICU to control blood pressure.
Yeah, the sudden IV. See, just practical, something practical. Then I'll get him to ICU and we start him on IV drop antihypertensive.
Oh,
Because you
yeah.
have to control blood pressure. It's very important after surgery. Okay.
Yes.
She recovered well and discharged home, but she called the clinic on the day 3 saying she had crush headache on the same side as her carotid. What you do? So she called you, I have a bad headache.
Mm.
So what you do? And what did I do? She called you, or her son called you? My mom, she having very bad headache in the area of surgery.
Yeah. I will ask them to attend to the hospital and to check the blood pressure, and
Yeah.
probably we
can-
need to do. Sorry.
Why need to come to hospital to check blood pressure? They can do it at home, the blood pressure. If you worry about blood pressure, they can do it at home.
Yeah, we can bring her for admission, and we do CT maybe.
Tell me what you're looking for, what you are worried about.
Still hyperperfusion syndrome, and probably stroke.
Hyperperfusion syndrome, no, usually, but some hyperperfusion syndrome you see after acute stroke, especially as TIAs, you know, but intracranial bleeding. So anytime patient had severe headache,
Yeah.
you have to think about intracranial bleeding. You know, this is like,
Yeah.
even next day, if the patient has severe headache, the first thing you have
Yeah.
to think about intracranial bleeding. So then you have
Okay.
to look for, you do a stat CT, head CT. So if the
Yes.
family call you, tell them, come to the ER, we're going to take a stat head CT. Okay?
Okay.
What you do. All right, now the blood pressure was 190. Duplex showed a widely patent, and CT showed demonstrate some edema with no hemorrhage. Right? We're looking for hemorrhage. There was no edema, but no bleeding, but she has an edema. That is why she has severe, headache. So what you do? The recovery pressure is very high, 190, 100. She has edema and hemorrhage. She has severe headaches.
Yeah, we call neurology team for assessment and treatment, proper treatment.
What her proper treatment will be?
We can stop the aspirin Plavix and
No.
control blood pressure.
Yeah, we need to control blood pressure, 190 over 100. And she has severe headaches. She has no hemorrhage now, but she may get hemorrhage anytime. This patient has to go to ICU.
Yeah. قريتها with hemorrhage معلش آسف.
Yeah,
With no hemorrhage, yeah, we control blood pressure. We admit the patient to ICU to control blood pressure.
Start on lower her blood pressure. We have to monitor very carefully because she can turn into hemorrhage anytime, So admit her, control her blood pressures, Even some people, they do an MRI because now, because, CT is not very accurate. So you may even get an MRI to see if she has reperfusion syndrome or, small bleeding you don't see in CAT scan. But the most important, you need to get her to ICU. You see, I don't care whatever you do, but I want you to tell me she go to ICU. If you send her home, this is a disaster. You see? So this is what we, in the oral exam, we want you to be safe. Even if you don't know how to control blood pressure, you don't know what to do, but at least you get her to ICU for monitoring. And we get, again, you can get a neurology consultation to evaluate her and treat her. It's the worst thing to tell me, okay, she's CT scan showed no bleeding. She's fine. I'll send her home, come follow up in the clinic after 2 days. This is a disaster. You see my point, Bassam? This is what we are looking at the exam, All right, what puts her at risk for conditions?
Hypertension and probably bilateral carotid stenosis.
Hypertension, yeah. All right. What are the clinical screening of cerebral hyperperfusion syndrome?
The mortality is high.
Why? What can cause?
Cerebral intracranial hemorrhage.
Cerebral edema.
And cerebral edema, yes.
edema can get to what? To the
Um,
why we worry about cerebral edema? It can cause what?
intracranial, the pressure in the intracranial will increase, and it might affect the spinal cord. So,
Right, when you get an edema, what do you get?
Mm.
Swelled up, and then no space to go to herniation.
yeah,
You get ankle herniation, and the patient may die because
yes.
the bones were herniated to the spine down. The reason why we worry about edema. Edema is very dangerous in the brain, you know.
Mhm.
About even, I mean, I think sometimes hemorrhage is better because hemorrhage is localized, you can drain it, but edema you cannot. They are very aggressive with the edema because the whole brain is swelled up. You cannot, like, you know, open a hole like in the what's the name? In the
The
skull.
foramen.
Drain it. It's the skull.
The foramen.
Yeah, to skull to drain it. So edema is very dangerous. So have to be very aggressive. You know, I'm not going to ask you how to deal with the edema. It's not our specialty, but at least you get it to ICU, get your consultation, control blood pressure, try to control her edema. But the most important, again, don't send her home. Okay. So again,
Yes.
headache after carotid is very bad sign, guys. I always tell them, so take it seriously, especially even after they don't have to go after home. Maybe sometimes next day, patients are complaining of headache. So anytime you do carotid surgery, a patient have a severe headache. I'm not saying like moderate headache or mild headache. Then you have to do a CT, head CT. This must be done throughout for edema or okay.
Okay.
All right. Wow, I was taking a lot of time. All right, let's keep going, guys. Case number 3. Yes, Bassam, any question?
How many station we have usually in the exam, and how long for each station?
You have only, I think, 4 stations. I remember last time was each station has two questions. Each one will different, like one carotid, one aortic, one peripheral, one something like that. So you'd be like separate, you know, scenario like that exactly. 1, 2, 3, 4. The only thing is different that we have the answer written, because this way we don't have a subjective, you know, feeling, you know, or I give you something like, you know. So when we wrote the question, we wrote down the answers, what you're going to answers. So when you answer this one, I say 1, 2, 3. If you answer only 2, then you take 2. If you take 3, then take all of them. You didn't answer any of them, you take a 0 on this one, you know. So this is the way it works. But the timing was problem last time. Like you see, now we're taking a time. You see, it takes like half an hour for a case, you know.
Yeah.
There, we have to be quick, you know. The reason why, again, just go to the point. Don't talk too much outside, you know, the point. Go to the point, answer it, and keep going, because you have next question. And all of them are practical questions. As I said, you can see here. We don't think about any percentage. I didn't talk about any number. We don't talk about any trials, you know. There's no time to tell me about the trials. I'm not going to ask you about, tell me about NASET, you know, or you know, or stent trials or any kind of trials. There's no time for that, you know. So all is just practical questions. We want you to know that you are a safe surgeon. What are going to do tomorrow when you go to the hospital and they call you for this case? That's all what we want to know. Again, your information is already examined. You already passed that, means you already have enough information. So the only thing you want to know that this information, you can apply it in your daily practice, okay? The reason why I keep telling you guys, imagine you are in the clinic. Exactly, just imagine you're in the clinic and patient walk in. And you're in the clinic, and this was scenario we're going to do next.
I'm sorry, Dr. Samer, I have a question.
Yes.
Like in the exam, the neuromonitoring, as you said, there is a checkbox. So if you ask me what I will do for my patient, and I said like stomach pressure, I didn't mention the others. I have to mention it, or like
No.
the examiner will ask if there is any more ways to measure the pressure.
Right. Usually, if the answer, like you have again stomach pressure, but usually like this answer, one of them will be enough. Like we put, like they say, what the, you know, monitoring. So the answers will be one is regional anesthesia, no monitoring, shunt all the time, measure the stomach pressures, or like TCO2. So any one of the answers should be correct.
So if I say I will shunt all my patient,
Yeah, that's
it's
it.
fine.
Yeah, it's fine. But then I may ask you, because I want to know if you know about,
Yes.
or practical. I'm not gonna say about percentage of stroke during shunt or something. I don't ask you. Okay, is any other way to shunt?
Okay. Yes.
Tell me, okay, yeah, there's other ways, so and so and so. So you have to know about it, Anything practical you have to know. Anything clinical you have to know about,
Thank you.
But don't tell me like if you what you gonna do. I can do stump pressure, original, or it doesn't work because you are in the war. We're going to do. You have to check up one.
Okay.
You can tell me, okay, we can do so and so, but I will do this.
I will only say what I will do.
Yes. If you want to do more, ask you, okay, is anything else? Is then yes, is there a way to do it? You say, what are you going to do? But like if you tell me I shunt everyone, right? I'm going to ask you, I want to be sure you are right. I say, okay, how you shunt? This is what my next question would be. How do you shunt? What kind of shunt? If you don't mention the shunt, you do just stump pressure, then I'm not going to ask this question. I'm not going to go this way. The reason why I don't feel the time should not be a time limit really in the exam, because oral exam is discussion, take and back and forth. When you have a time limit, I don't think it's a good idea, but it's the way they put it. I don't know why. Because the whole idea from I want to be sure, so I want to take my time to be sure that you understand what you're saying, what you're doing, it's not like 1, 2, 3, 4, 1, 2, 3, 4. But this is the way they instructed last time. I don't know this year, guys, so I'm not involved, so I don't know really what they're doing. But this is the way it was last year. But this isn't everywhere, even in the United States. This is the way it's an exam. It's a clinical exam, practical exam. Okay. You want to be sure that whatever you say, if you don't know it, don't say it, because it's the worst thing to say something you don't do. Like if you say, okay, I'll do a stump pressure and you don't know the stump pressure, this is a problem. If you don't mention, it's okay. We do a different way. You get my point?
Yes.
All right. Who wants to take the third one?
I will take it.
Huh?
Yeah, I will take it.
Okay. Go stay number 3.
Start.
Yeah, go ahead, please. You can see it, right?
A 76-year-old man present to the ER with complaint of left arm and left leg weakness and the right facial droop. He's an active smoker. Neurology evaluated the patient and heard a right neck bruit. They are requesting a vascular surgery consult. He takes a daily aspirin and high dose statin.
Okay.
So he have right facial droop and left weakness.
Okay. So he's a stroke, right?
Yes.
Okay, let's go through the questions, see what is the question here. How would you proceed? So you're in the ER, they call you from consultation. This is the patient, he has a weakness, all things. What do you do?
I will take more history, focusing on risk factor for atherosclerosis like DM, hypertension, hyperlipidemia. I will ask about signs or symptoms for aphasia, any previous history of TIA or stroke. I will examine the neuromotor function.
Stop. So you did that, you examine him and he has a weakness on the left side, you said. It has been 2 hours since he presented, has now resolved. That he has happened a few times over the last months. His neuromotor exam is back to baseline and equal bilaterally. So what you do? So patient.
Did we do for him investigation like ultrasound, duplex, CT?
Okay. So you get 4 duplex ultrasound, right?
Yes.
Okay. And check also his sinus rhythm, because maybe it's atrial fibrillation, So you have to check.
Cardiac evaluation.
Okay. So he said that his stay has been more frequent and timing between them is decreasing with information what you do next step. So he getting more TIAs. He used to take like every 6 months. Now he taking like every, 2-3 weeks, he's getting TIAs. What to be
And
your
like, yeah, he's having like crescendo TIA.
No, crescendo is different. Crescendo, when you are in the OR, in the hospital, I wasn't like same day. We're talking about here weeks. You know,
Mm.
it just tell you that he's getting more TIAs, so that means you just have to be more aggressive with him. Crescendo TIAs, that patient admitted with the TIAs, I planned to him surgery after 2 days, and same day he get other TIA. And then after 2 hours,
Okay.
TIA, recovered in TIA. Crescendo, like within 24 hours getting multiple TIAs. But if
Yes.
it's different, then we don't call it crescendo. But
Okay.
that means you have to be aggressive because that tell you the plaque is not stable.
Yes.
So
So after the evaluation and do CT, I will offer I will offer him surgery, carotid endarterectomy.
okay. So first you want to be sure there's no stroke, so you did a head CT, correct?
Yes.
Angiogram, because you want to confirm the stenosis. You had a head CT, be sure there's no stroke or no hemorrhage, okay? And then you do carotid duplex ultrasound, and let's say the carotid duplex ultrasound showed high velocity, okay?
Okay.
Then we're going to do a CT angiogram to see how degree is stenosis, okay?
Okay.
CT head is negative for acute stroke, and CTA showed high-grade lesion of the right internal carotid artery. EKG and echo is normal. What you do next? So echo is good. Now, no stroke, but you're having TIAs, but again, getting shorter and shorter.
I will start the patient on aspirin and high dose statin, and do carotid endarterectomy within after 2 days, but within 2 weeks.
Okay. Yes, I'll do it as soon as possible, really, because again, he getting more TIAs,
Yes.
but within 2, 3, 4 days, maybe something like that. If the TIAs is not getting closer, like crescendo is different. Crescendo you do the same day. This one is an urgent, because again, TIA is more closer and closer. Then we have to do it really soon, maybe within 2, 3, 4 days, something like that, But I will not wait like for a month or 6, 8 weeks. No.
But for crescendo, I can do it within 2 days, right?
No, crescendo has to be an emergency, same day. It's an emergency.
Same day. Okay.
We had the patient last week. We have it carotid. He came as TIA. We're supposed to do him next day, but the same day he get other TIAs. And we knew if he has a crescendo, then we do it in the middle of the night. We did emergency.
Oh, okay.
Yeah, when you get like same day, a couple of them coming, then this is a crescendo TIA. They have to be done an emergency because you don't know. That means that the plaque is very unstable. It can get stroke anytime. You cannot even wait for next day. Okay. This is crescendo, not this one. This one is just an urgent case. This is just unstable, getting closer and closer. So I think
the crescendo, by definition, it's like listing the frequency within days, not weeks or months.
I would say even within hours, not even days.
Okay. Okay.
Yeah, one, like a same day or next day. Like you get the patient today at TIA, same day get other TIAs, or maybe next day. So then I will do it right away. Yes. What time frame would you plan to operate this patient? We said about 24 to 48 hours. Describe your surgery. We went through that many times. You don't have to go through that again. The patient wake up and is not moving his left side. What do you think is going on?
In the recovery, I'm assuming, right?
No, he said wake up. He didn't say recovery. Patient wake up, you're on the table, you're on the wall, and he doesn't move his left side.
Since it's early, most probably technical issue with my anastomosis. So I will do bedside ultrasound, and I will recognize the patient. I will for probably redo the surgery.
Yeah, I mean, if it's again, this is just wake up now, and he has neurological symptoms. I mean, like deficit. Then either he emboli or is acute thrombosis. Like you are still in the ward. It's different here from recovery. I mean, it depends. The teaching, all teaching tell you have to explore right away. be the safest way because you're still in the OR. It's very easy, you know. Like you do aorta biofilm and the graft clotted. You don't get the CT angiogram. You're on the table, just open,
Yes.
right? Like you do fem pop in the OR. And after you finish, your fellow tell you, oh, I don't feel a pulse. You're not going to get ultrasound to confirm it. You don't get a CT angiogram. You're in the OR, you know, and the recovery is different. You already moved the OR, then I may have to get to confirm it. But as for in the OR, always I prefer just, you know, just go and explore it right away. Unless if you have very quick access to the ultrasound, like in our room, but it's not the scenario everywhere. Like in the King Faisal, we have ultrasound in the bed. I just get it very quick and have a look. But if you don't have ultrasound, it can take a half an hour for the guy to come. You're doing after hours, you know, then just go and explore. So again, be on the safe side, I would say I just go and open him up and explore to be sure that my case, my endarterectomy is fine, is not thrombosed, okay?
Sure.
Tell him I will do the ultrasound, but it has to be like stat. It has to be like
Yes.
within 10 minutes, you know, it has to be
Yes.
on if you want to go this pathway. As I'm saying, in the oral exam, you can go either way, but you have to defense it. Okay, but if I tell you what, okay, say our ultrasound, say as ultrasound technician in the home at home, and it takes him like half an hour to get here. What are you going to do? Are you going to wait for him? What do you answer?
No, I mean that the ultrasound is ready beside the OR.
Yeah. So if I tell you this way, you tell me no. I will not wait for him. I'll just go and open the patient and look for them. Okay.
Yes.
All right. So what time frame would your scan patient wake up with no, the repair had thrombose? What your plan now? So you open and found your area thrombosed.
I will clamp the common carotid external. I will not clamp the internal. I will open the patch as we said previously, and after the thrombus removed, and check for back bleeding. Maybe I will do the Fogarty to take any debris.
Okay, so the same what we talked about before.
Yes.
You open your back or the arch or suture line, whatever you did it. You do thrombectomy, you do gentle embolectomy. Very
Yes.
important to be gentle because if you just say embolectomy, they may freak out, you know.
To avoid complication or a fistula dissection.
What is that you're talking about?
Embolectomy, I mean.
Embolectomy is risky because if you go blindly, you can cause perforation inside the brain. So we just go like one thing, like 1-2 centimeters. That's all, just to be sure that distal. But I don't go inside the brain. No way.
Yes.
Don't go to the ear level really. So you don't go more than 2 or 3 centimeters. You know? Just very gentle. Just be sure there's nothing left, you know, stuck there because the clot is only in the camp because it's just very fresh clot. You know, it just happened. So you do that and you see dissection. Let's say you have most of you see a dissection, and so you move successfully with the carotid. You cannot reach out. So you saw dissection, but it's distal to where your patch, and you cannot reach it. So what you do next now?
As we said before, we'll extend our incision and try to tack it with suture.
Okay. And if you cannot, then you do a stent, as we said, from the common carotid.
Okay.
Yeah, but it's very important to dissect distal. You have to see the flap very well. So if you don't have a space, I will just go with
Stent.
yeah. All right. What else? With the current arteriotomy, you cannot reach out. There were no changes in the neuro monitoring to indicate the need for a shunt. The repair was successful, and the patient awake without neurological deficit. What do you think was the cause of the distal dissections? Why you think why it's happened? It's technical error, right?
Yes. Or maybe the shunt also.
Use a shunt? I don't know if you use a shunt. We didn't use a shunt here. Usually when you use a shunt, then you see dissections the whole internal carotid artery. You don't see only the here at the tip of the
maybe when we were doing the endarterectomy.
Yeah, because when you do endarterectomy, you didn't pay attention to the distal and you miss it, you know. So the reason why you have a flap and you get dissection. So this is from not tacking the distal intima, and there's a flap which you miss it during the surgery.
Okay.
For this reason, some people, as I said, they do duplex ultrasound all the time to be sure that, you know, there is no flap distal. All right, nothing really information much. I mean, the most important in this question is to know that if this happened on the OR, because the other one was in the recovery. But in both scenario, guys, you have to have tendency to take him back to the OR. This is the first thing the examiner want to hear. That you plan to take him back to the OR.
As long as the patient in the recovery or the OR will take him back. Outside,
This is the safest way. And if you want to be more like practical, do ultrasound, I have no issue, but it has to be quick. But all the teaching tell me if you take him back, nobody will argue about it. You know, take him back. This is a safe side to do. Better to be unsafe than be sorry. So I'll say, okay, in the recovery done, I'll say, try away the OR. I want to first, you want to be sure that your repair is fine. If he asks you, can you do duplex? Say, yes, I can do duplex, but it has to be like next to me and very quick. You know, I cannot wait for it. You know, I have to be sure that our repair is fine. All right.
okay.
All right. Case number 4. Well, let's go to Rafat.
Okay, Dr. Samer. Yes, please.
Let's go here.
79 years old male with the history of the previous, I didn't see. Right side carotid endarterectomy 10 years ago. Is beginning to forward with the routine duplex. He is former smoker and has never stroke or TIA. Physical examination remarkable with well-healed carotid incision and normal neuro exam. Carotid duplex ultrasound show peak systolic velocity is 400 and the diastolic velocity is 150 of the right carotid artery.
Okay, so what do you think this patient has?
This patient is follow-up post-carotid endarterectomy. Asymptomatic. On the follow-up, there is stenosis, but is asymptomatic.
For his remarkable, he's well, he carotid, yeah. So he has asymptomatic severe stenosis, recurrent severe stenosis, correct?
Yeah.
Okay. What do you next? What do you do next? So he came to
We started to take the history and examine the patient for the history if there is any neurological deficit or TIA, stroke, weakness in the upper limb or lower limb, facial drop or the eye mononuclear deficit. History of smoking, if still history of medication, is comparing to the medication or not, claudication of any cardiac issue. Then I will examine the patient, neurological examination and neck examination if there is any PROI or something. After that, I will start to yes, please.
So what you going to do you do RCT angiogram or no? Do you do anything or no? His velocity is 400. That's like 150. So he has severe stenosis. We're looking for CT. What the criteria for asymptomatic recurrent stenosis? Should we fix it? Should not fix it? We stent it, leave it alone. Hello? Can you hear me?
Sorry, Dr. Samer. Yeah, depended on the stenosis. If it is more than 80 or low, symptomatic or asymptomatic patient. If the patient symptomatic should be fixed. If asymptomatic more than 80 should be treated.
Yes, I mean, it's controversial issue. If symptomatic, nobody argued that you need to fix it. If it's asymptomatic, most of the people wait until like maybe 90% because restenosis usually is a benign process because it's not intimal, it's not a plaque, it's intimal hyperplasia.
Yeah, yes.
So as far as patients asymptomatic, most people, they watch it unless it become really like 90% stenosis, afraid of occlusion, then people may consider it. But this is an area which is a controversial. We don't have a strong evidence. It's the way you guys discuss, you see, in the exam, you see. The way how you can talk, you know, you can say, okay, we don't have a strong evidence, we can go both ways. but most of the time restenosis is a benign, so we are more into the medical management. Unless I feel it's very stenotic and I'm afraid that may occlude it, then I may consider fixing it. Okay. Especially if you do a serial ultrasound and every year the velocity is going higher and higher. Okay.
Yes. Okay.
Do CT angiogram. It's very important to CT angiogram because you want to see it. There's a long stenosis, short stenosis. It's easy to be fixed because how we fix recurrent stenosis usually?
Recurrent
What's the best
stenosis, but surgery, patch, repatch again, or interposition, or interposition graft or stent.
Okay. How would you fix it?
Surgery.
It's up to you. It's not a question. You tell me whatever you want. I mean, you can go whatever you want. Just tell me why you want to do it. What's the risk? I'm saying it's not right or wrong question. I just want to know what you. Yeah.
It
like
is dependent on the patient. This fit for open surgery is better.
He's fit. I mean, this is a scenario. Exactly. You can see in front of you. It's a scenario. 79 years old. He never had a stroke or TIAs. Yeah, looks healthy. 79.
Yeah, it's better for him surgery. Like explained to the patient more than 5 years, I will go for surgery. There is no history of necrotization or anything, or surgery.
Why
Open.
not? Why not stenting?
It can be by stent, but surgery is better than.
Look, you see, this is what guys you have to know in the exam. We go back again to how you think. It's an all thought process, you know. I ask you why not stenting, you know. You can tell me it's better. No, it's not better. Nobody knows. You can tell me because, you know, with a surgery, there's high risk of nerve injury, right? Because the redo, where in stent is a less chance of nerve injury. That is why I prefer a stent, you know. But
Yes.
and okay, because this is a redo, it's more difficult, it's more scarring, it's more high chance of nerve injury. And all studies showed high chance of nerve injury with a redo. Where with stent is less chance because you don't do that, right? But on the other way, you can tell me no, the stent is not good. You see, if you want to go with a stent, if you want to go with surgery, you can tell me no, stent is not good. I know it is less chance of nerve damage, but it's 79 years old. And all studies showed that in old people, more than 70, the stent do worse than surgery because of the arch, because most people they have a disease arch. And 70 years old, they do worse with the stent than surgery because chance of embolization from the arch. So you can tell me the reason why I prefer a surgery. Okay, I tell you why you just didn't do a TCAR. TCAR would be the best option, but you tell me we don't have it here in Saudi, so I don't do it. But maybe it's the best option for this patient really is a TCAR, because this way you can avoid the arch, so you avoid the negativity of transfemoral stenting, and you avoid the problem with the surgery, which is redo. Then I do a TCAR. You see, guys, this is our thought process. How do you think? How do you discuss the case? You know, but none of them is right. And you can go with surgery. Yes, you can go with this one. But I want to know why you choose this one, not the other one. Okay. All right. So let's next. Patient has a steep type 3 aortic arch, but meet the criteria for TCAR. What protocol instruction will you give him? Well, I don't think this question will come. We don't have TCAR here in the. And you don't have to know about TCAR, guys. I don't think you need to know. Maybe you have to know the principle that how we do it, but I don't think we're going to ask you how to do a TCAR. Patients on those medication is ready for operation. Describe your procedure steps. Okay, this is the one. Okay, so you said you're going to do a surgery. So how you do redo surgery? So
yeah, the same.
The same. What's different redo? I don't know if you saw any redo before or not.
I didn't see.
We did not. Okay, you can tell me. You can tell I didn't see it. If I tell you, tell me exactly what you do, or how it's different from cardiac endarterectomy. You can tell me I didn't see it really, but I read about it. You have to know about it, you know, because you may have to do it sometimes if you don't, even if you didn't see it, but it's the same technique. The only difference is that there's no plaque here, so there's no endarterectomy in the redo. It's a stenosis from intimal hyperplasia. Usually we just cut it, and then we just put a patch. So this is the only difference between redo and cardiac endarterectomy. We don't do them much, but if you have to do them, it's the way you do them. You just got longitudinal where there's a stenosis and put a patch. Don't start doing endarterectomy because again, the whole surface is smooth. And then you may end with a problem distal and all the things. So it's better this way. I mean, it's not wrong to do endarterectomy, but if you do that, then you can to cut distal. There's no plaque to end, so you have to cut distal sharp with a butt scissor, and then put a couple of stitches to tack the flap distal because be a big flap there. You have to tack it. Or if you feel comfortable, just open, put a patch, and get out. And you're done with that. Of course, these days the best way to do is with a stent and with a T-car. All right.
Okay.
Most common technical complication. This all talk about T-car. I don't think it's a good question because we not do a T-car here. Let's take next question.
What is the size of the stent?
Size of the stent? Okay, well, let's talk about stenting a little bit because they may ask you about stenting. You know, we have two ways of stenting. We have transfemoral and transcarotid. Transcarotid is a T-car, which is, you can tell them we don't have it here. Now it's much better really than transfemoral. This is the way most people now go, but we don't have it. So we'll do transfemoral stent. If you tell me, then I can tell you guys how you do a stent. Well, let's go back to Rafat. Let's say you're going to stent it transfemoral. How you do the stent? Have you ever seen a stenting? What is stenting?
Once time, I will
So then you tell
from
him
the femoral.
before you start, Rafat, you tell him, I just saw it one time. I'm not familiar with it, but I can tell you the step, okay? Because I know you're not going to do it, you know. So this is the way I would start, but don't talk confidence. Oh, I'll do stenting. Okay, tell me at the stenting, and then when you start telling me the stenting, I know from your step that you never did it. Then you'd be at trouble. So it's normal to say I didn't see it or just saw once. You know, I don't think I will do it, but I know the step, and this is a step 1, 2, 3, 4. Then you tell me what the step. Okay.
Okay.
So what the step?
From the femoral artery functioning by guided ultrasound, then re replace the sheet, the heparization of the patient over the wire, regular wire, pass to the arch, aortic arch, then pigtail inserted over the wire until the ascending the aorta, then aortogram done to show the common carotid artery. Then we'll use it.
How you put the C-arm? What the position of the C-arm?
Left lateral oblique.
Yeah, left. So you can open the arch. Okay. Then
Yeah.
you cannulate the common carotid.
The common carotid.
And after that,
Then,
what kind of wire you use? Usually use glide wire. Okay.
Guide wire. Yeah.
Glide wire. What catheter you use?
Angulated catheter.
Yeah, but what type? You see, that's the reason why I know if you use it or not. See how I can know if you did it before or not. From this question, I can tell if you did it before or not, you know. So we have different type, you know. Is the best one GB2, but it depends on the arch, you see. So you cannot say it depends on the arch morphology because every patient has different arch. So I just choose the right catheters, but we have different one. We have GB1, you have GB2, you have C1, C2, you have vertebral catheters, yeah, head hunters. There's a lot of different catheters depend on the morphology. Okay, so you can read the common. What do you do next?
I will again do angio to confirm the internal and external artery. Then pass the wire to the internal or the occlusion, the diseased area. Then use the stent over the wire deployed at the lesion area.
Okay. You see, if you answer this one, it's better to say I didn't see it, you know, or I don't know, because it's a lot of steps very crucial, which is you miss it. So I know. which is okay. It's not. I'm not criticizing. It's okay. I mean, guys, you didn't see much stenting, which is okay. Now much intervention done by intervention radiology للأسف يعني. But other people they don't do stenting, which is okay. I mean, we don't have to know everything, you know. So no, when you go first after you connect the common, you go to the external first, not the internal, because first you have to change your sheath. You have to put the big sheath in the common carotid.
Yes.
So you need to change the wire to the stiff wire. So you go with the glide wire to the external. You put your vertebral catheter, whatever catheter in the external. Then you change to the super stiff wire. Then you change your sheath to the long sheath because you need sheath in the common carotid. Then you put your sheath in the common carotid. Then you take the wire, and then you get the filter. You have to do a filter first before you do anything. Then you get the filter. Then I'll ask you what type of filter. We have different type of filter. Then you pass it with 014 wire with the filter. You deploy the filter, and then you do stenting. Do you do ballooning before stenting? No, we don't balloon. You just primary stenting. And after when you do primary stenting, you have to tell the anesthesia is a chance of bradycardia or asystolic, and they have to be ready with atropine. And then you stent him. The most important after stenting, you don't want a perfect result. You have to end with at least 20-30% stenosis. You don't like Lowaxin, you don't do oversize all the way with 5. Even if the artery is 5, we oversize with 3 or 4 millimeter balloon. That's all. Because if you squeeze it too much, you get embolizations, and this is very dangerous in the brain. So you have to, and the balloon should be very quick, in and out, very quick, then because again bradycardia and asystolic. So you have to be very careful when you're ballooning or when you stent. And after that, you check your angiogram. Okay, let's say the angiogram showed no flow distal to the stent. What do you do? Any of you guys know? Maybe Bassam, he knows this one because saw a couple of cases.
No flow after the stent?
You stent, you put your filter, you stent, you balloon, your angiogram, there's no flow distal to the stent.
Yeah, maybe there is dissection, so we have to extend our stent or do extension. We do thrombectomy and stent.
This is possible. What else could be? This is could be possible, but this is not the most common. The most common reason is that the stent is a filter full of clot, of debris. You know.
Okay.
First thing, you remove your filter.
So the angiogram, you did it before removing the filter, usually?
Yeah, before you filter طبعا filter آخر شيء بتشيله. إذا كان في بدك تعمل شغله ثانيه في restenosis, you have to balloon again. So always do an angiogram before you take the filter. You know.
Yeah.
And now comes the advantage of the one we use. It was called ambush shield, comparing with the other one, which is
Spider.
So spider with the filter. So when I remove the filter, I remove the wire with it.
Yes.
A problem, because if this is a dissection, then I'm in big trouble because I don't know if dissection or filter. I'm just guessing. But with the ambush shield, I can remove a filter, a wire still there.
Yeah.
So we remove the filter. Second thing could be a spasm. So we remove the filter, we give some papaverine, we do our what's the name? Vasodilator, then we do an angiogram. If it's still no flow, then it's a dissection. Then I have to stent. But the good thing, my wire is still in the true lumen, you see? There's the advantage of, but if you do a spider, then you lost the wire, then it's very hard to go back to the true lumen. Then you are in big trouble,
Yes.
And so this is what, and I saw this cases, but all the cases was from the filter, because it was full of, so moment we remove the filter, we do angiogram, and everything will open up very nicely. So this is the first thing you think about it, the filter. Second thing, vasospasm. The last thing you think about is dissection. But any of them could be correct. All right. Again, stent, you don't have to know much, guys. But again, if we get to this point, just say, I don't do it, This is simple.
Usually in the carotid stenting, we don't do balloon.
Good. Sorry, Wiz?
With the carotid stenting, we don't do ballooning after the deployment.
Yes, after deployment, very gentle. You do deployment, yeah. But very quick. Some people say don't do deployment, don't do ballooning, do angiogram. If it looks fine, you And you deploy only the middle part. You don't deploy the distal ends because you don't cause dissection. So, but some people, they don't do ballooning. You're right. Some people, they just become afraid because the most problem comes with the ballooning because every time you embolize or cause asystolic because you compress the vertebral, the carotid body. But I prefer to balloon. But again, with the low profile balloon and very quick, like in and out. We don't keep it like we do with our XMT, like 30 seconds or 1 minute. No, just 2 seconds, open and in and out, you know. But you can go either way. Right? Everyone took his chance, guys, right? 4 cases. Sorry, I thought we'd go faster. You want to continue or I have enough?
Continue, Dr. Samer.
Okay, we did this one or no? I forgot. Number 5. We did number 5, right? Number 4. Try endarterectomy for symptomatic 10-year present occurring to separate occasion. Try TIA last week. We talked about this one. This is a redo, right? Or it's different? Well, let's
This
go.
is sure.
Again, I think, guys, in the exam, most probably you can get what we do. I mean, now this is more like, you know, more rare cases, you know. But in the exam, most probably you can get what we get, like, I think, symptomatic or asymptomatic carotid stenosis, how you deal with it, how you approach the patient, you know. Or second thing, patient came with acute stroke. Let's talk about acute stroke. Patient come with acute stroke, you know. I mean, we present case, but in our case, the patient recovered. Well, let's say he did not recover. The patient come to the ER. He said, his family said, like, you know, he was having breakfast with us 2 hours ago, and now he has right arm weakness. He come to the ER. What do you do first? Well, let's get Muhammad.
Yes, doctor. So if it's 2 hours and the patient fit, we can offer for him thrombolytic therapy and admit him under stroke team thrombolytic therapy, and
Okay.
we'll see how. Yeah.
He did thrombolytic, and then he has, you know, severe headaches.
We'll do CT brain. We'll make sure that it's not transformed to hemorrhagic stroke.
But
And,
what's the problem, Muhammad? That the first thing when he came to the ER, right?
we did the CT scan and we make sure it's thrombotic. And
When he came,
I have it. Yeah.
when he came to the ER, he came with a stroke.
Yes.
Correct?
Yes.
What type of stroke we have?
Hemorrhagic and thrombotic. We needed to do investigation. I thought it was already done in emergency. Sorry, doctor.
No. So, and which one is the most common? The hemorrhagic is more common already. So, from hypertension. So, first thing, you get CT scan to be sure there's no hemorrhagic stroke before we do even. So, we do that, and then it's negative, then yes, any embolics, you know. Then you give him heparin. And then when you give TBA, do you give TBA peripheral, through peripheral line or through catheters?
No, he can have systemic heparin. It does need to be catheter directed heparin for stroke.
You have or you have not? I didn't get it.
No, he can have it peripheral for MI and stroke.
Okay. So when you do the transcatheters?
For lower limb angio and for mesenteric angio. Yeah.
By the way, they do that. The stroke team, they take him right away to cath. So you can go ahead.
Yes, doctor. So if it's less than 4 hours, he can have systemic ateliptase. If it's more than 4 hours, he can go for catheter-directed thrombolysis, and it can reach up to 1 day. They can offer it up to 12 hours as a golden hours, but they sometimes try up to 1 day.
This is the correct answer.
Yeah.
The way you should answer. You're right. Less
Yeah.
than 4 hours, peripheral TBA is enough. More than 4 hours to 1 day, you have to do a transcatheter TBA.
Yes.
So I'm not going to ask you how you do it, but I want to know just what you do, you know?
Oh.
How you're going to do, because this is more neuro interventions, okay? So we do that, and then he recovered. We do cardiac ultrasound, and he has like 90% stenosis. So when you do his surgery,
So I have to make sure that he's functionally recovered.
okay,
After that, I can offer the surgery as we discussed between between his recovery, 48 to 2 weeks.
okay. Well, you said if he's recovered, what else you have to look for it? Otherwise,
So what else as a physical exam?
no.
Mhm.
To decide to do when to do a surgery or to do a surgery, even it has to be
Yeah.
recovered.
So I need to do a full physical examination, making sure that this patient is neurologically recovered. Then I will CT his brain again. I make sure that he has no intracranial hemorrhage that may affect my treatment, and they will check the plaque again in the CT scan.
Okay. But in the brain, in the cities, they have a criteria which we decide to go with the surgery.
Yes,
What's
the size of a stroke, it should be less than a coin. So our yeah. Yeah, there is difference. This is هنا اللي يقولون less than a coin, بس هو بالعادة it needs to be less than 1/3 of the hemisphere, or yeah, less than 1/3. Yeah.
Why don't say it if you know this information? Looks, you know the information, but you don't say it. Yeah.
Yeah.
If it's less than a third of the brain stroke, then yes, you can do a surgery. Don't wait, because some people, they used to wait like 6 weeks, but now we can do it if patients start recovering. It don't has to be full recovery, but he started gaining recovery. Stroke less than a third of the brain, and the Glasgow should be how much more than, you know, the number?
Glasgow comma? What, doctor? Sorry.
The neuro exam. Well, Glasgow.
No, modified Rankin score. It's less than 3.
Not Glasgow coma.
Yeah. Less than 3. So he can be fully dependent on himself.
So you see, you have to tell me this information. Then you do a surgery within 2 days to 2 weeks. This is the way you do it.
Yes.
Again, this is an important, guys, because it's an emergency. So I think this scenario, you have to know about it. So patient came to the ER, stroke, he did not recover, CT, heparin, less than 4 hours, TBA, more than 4 hours, transcarotid catheterization with a TBA or embolectomy, mechanical embolectomy. And then surgery within 2-4 weeks, but you have 3 criteria: rank less than 3, stroke less than third, brain damage less than third, and he's partially or fully recovered. You know, like he functioned like rank 2 or 3, as you said. But this is criteria. All right. Anything else? Patch, guys. Do you patch or don't patch? May I ask you questions? What do you guys ask?
So the batch showed in the study that it decreased restenosis in the future. So I will batch all my patients.
Okay. I patch my patients. Some people say that I don't patch. Unless it's less than, you know.
6 millimeter.
Yes, 4 millimeters, 6 meters.
4. Yeah.
It's more than 4. You don't patch, but some people patch. I can patch all the time. Some people patch only one because it's more on artery. So you can argue. You can take it for there's no right answers. You know.
Yeah.
As we shunt, you can be selective. You can shunt all of them. You can whatever you have to do, but you have to do, you know, selectively and have a reason why you do that or not do that. Common carotid stenosis. We don't apply criteria on the common carotid. Common carotid stenosis is completely different from internal carotid stenosis. You know, we treat only symptomatic one. We don't treat asymptomatic common carotid stenosis. That's an important. You know, only the stenosis that common. Mostly we treat with the stenting because most of the time is the origin, and the safest way is to go retrograde. You know, it's the safest way. Because the common carotid, by the time you put your wire and sheath, everything, you already cross the occlusion, so you get emboli. So the safest way to do common carotid stenting is to go retrograde from the common carotid artery. This way you kind of clamp it, flush it, stenting, and then you can open it. So there's chance of embolization. What else? In-stent stenosis, if you get any patient with a restenosis inside the stent, we treat it conservatively. Again, if it's asymptomatic, becomes symptomatic, the recommendation to re-stent him again. What else, guys? Have any question about carotid so we can done with this subject? Again, you don't need to study about the trials. You don't need all these headaches, you know.
I'm infected, doctor. Like if the scenario came, I had patient to TIA, I did batch, and after a year, this batch get infected. So the approach, what is the best approach? Is it interposition venous graft
Yeah,
with
that's
saphenous? Yeah.
venous vein graft, you know.
Okay.
Stent is not a good idea.
Okay.
Aneurysm, usually resection is the best way, unless if it's very high, then you may think about cover stent. We don't use cover stent in the carotid artery unless for aneurysm, because we use a bare metal stent. Now they have a mesh stent, which is not available yet. What else?
Traumatic dissection, carotid, doctor. What is the best approach? Symptomatic traumatic dissection.
If it's asymptomatic, leave him alone. If
With aspirin, yeah.
and dual antiplatelets,
Yeah.
and proper CT scan. If it's symptomatic, it depends. If it's something you can reach easy with a stent, then I'll stent him. If it's very high intracranial cavernous sinus area, I'll treat him conservatively also. So with the antiplatelets, unless he recovered, unless he recurred symptoms in spite of antiplatelet, then we may consider stenting. Yeah.
Okay.
But try to be conservative with the stenting, yes, with antiplatelets. Unless he get recurrent symptoms while it's antiplatelets, then you can think about stenting. But don't jump to stenting right away.
What is the duration for antiplatelets?
Durations?
Yes.
There is really, you see, we talked about that last time. We don't have any studies to tell us how much we use and how long, and should we use single or dual antiplatelets. Most of our, recommendation take it from the coronary really artery recommendations. Again, I mean, you can go either way. You can go single, you can go with a double. It depends. If you fix one artery and the other artery is clean, I think 1 year is enough. But if he has stenosis on the other side, which most of the time he has like 40–50% stenosis, so he has to stay on antiplatelets for life. But if the other side is clean and one side you fix it and it looks clean after 1 year, you may be able to stop them. But I never saw this scenario. Always he has stenosis on the other side. Maybe it's not as significant as the side you fix it. The reason why most of the time they stay with antiplatelets for life. Maybe you don't have to be on dual, maybe single is enough.
What if it was asymptomatic dissection and we treated with antiplatelets or anticoagulation?
No, you antiplatelet. You don't give anticoagulations with the dissection. We just give antiplatelets. I give him dual antiplatelets, and the most important is to follow up CT scan or duplex
دكتور سامر كأنه الكادس ترايل قارنت بين الانتيكواجولانتس والانتيبليتلتس الدول and single, and there was no difference between all agents over a 12 months follow-up post dissection.
Where's the dissection? Carotid?
Internal carotid. Here mostly based on vertebral dissection, but they reflected their data on the internal carotid.
Well, you see, I tell you, they always take it from somewhere else and put it here. Yes, I mean, it depends. You can go single, double, this is something like a gray area. So for the exam, don't worry, guys. We don't ask you about something like a gray area, And if you answer single, I'll accept. If you tell me dual, I accept. We don't have any strong really evidence for any of them. And if you give dual, it's not wrong. If you give me single, it's not wrong. So I'll accept any of them.
Okay.
Any other questions?
When do you want us to
We have
meet again, Doctor? Yes.
let's do it.
Well, because we need to do. What do you think about next one? We can do aortic or peripheral?
Up to you. What do you want, guys? Peripheral or aortic?
Aorta.
Hmm?
Aortic.
Oh, yeah, let's talk about aortic because I'm sure I'll get one aortic.
Yes.
In the meantime, if you have any more question about carotid, we can discuss it. You know?
Okay,
But like,
sure.
the whole idea from this meeting is not to give you information, you see, it's just to practice how to get your information. Like sometimes Hassan Muhammad, I know it's like I'm taking information out from you. You have the information, but you not give it to me, you know?
Okay.
So I ask. So I'm just trying, guys, to practice again. Practical, you are in the clinic, you see the patient, how to approach this patient, how you deal with this patient, you know. So again, there's not much information to memorize, more practice, you know. All right, guys. Well, let's meet you Tuesday. They say maybe 7 p.m. Let me see if anything is okay for you on Tuesday.
Yes.
Wait, okay.
Okay.
The only problem, guys, many people, they ask me they want to join us. Is any problem if somebody just listen to us when we discussing? Because I keep getting the question, you know, people ask me, or you prefer to keep it like privately?
Private.
Huh? Sorry.
Keep it private.
Keep it private? Okay. It's up to you guys. Can, okay, after we finish, put it on so people can learn from it. Can put it at least on the after recorded one, or you don't want also that?
It's okay, doctor. Yeah, for this is fine. Yeah.
The benefit of people. I mean, that's all.
Yeah, they can benefit. Yeah, but keeping the group is so small. It's yeah, it's better for us.
It as recorded case. They can listen people after we finish.
Yeah.
You prefer this way?
Yes, doctor.
No problem. All right, so we'll meet Tuesday, okay?
Okay, thank you so much, doctor.
You take care.
Thank you,
Bye-bye.
Dr. Samer.
Thank you. Thank you.